let's say. Okay, picture this. You're trying to spot a tiny, almost invisible fracture in someone's wrist, maybe in that tricky scaphoid bone.
Yeah, the one that's notoriously hard to see.
Exactly. And to get that shot, you can't just do the standard X-ray. You might need to angle the tube just so maybe, 20 degrees towards the elbow?
Or even hyperextend the patient's hand into a position that's, frankly, pretty uncomfortable.
And the centering, it has to be perfect, down to the millimeter. Because if you're off by just a couple of degrees...
Poof. That fracture disappears on the image. It's basically invisible, and the image isn't diagnostic.
Right. And that tiny difference, that razor's edge between seeing the problem and missing it entirely, it all comes down to executing these positioning protocols perfectly.
Mm-hmm. Welcome to the deep dive. We've got a ton of source material from a listener today, all about the essential X-ray views for the upper limb, fingers, hand, wrist, all the way up the arm.
Yeah, it's a lot. But we're not just going to read a textbook at you. Our goal here is to sift through all this technical stuff and pull out the core ideas. Why these specific angles? What exactly are we trying to see? What makes an image good enough?
We're thinking of it as climbing a scale of precision. Starting small with the fingers and then working our way up to the really complex stuff like the wrist and elbow, which are, the real tests of skill.
By the end of this, you should have a much better feel for the incredible level of detail, almost like forensic work, that goes into getting these medical images right.
Okay, let's dive in. All right, so before we even talk about angles and beams, we need to lay the groundwork. Safety and prep. Our sources all agree the very first thing, absolutely critical, get rid of any artifacts. And they mean anything. Watches, rings, bracelets, they all have to come off. It's not just about them blocking the view of the bone either.
Right, even small bits of metal can scatter the X-rays, right? Degrade the whole image.
Exactly. It messes with the contrast, makes it harder to see subtle things in the soft tissues around the bones.
And there's the practical side, too, making sure the patient's stuff is safe. Taking off jewelry is one thing, but the procedures emphasize you've got to secure it properly, put it somewhere designated.
It builds trust. It's a part of the whole professional standard.
Okay, so artifacts off, belongings secured, then positioning for patients who can walk and sit easily.
Ambulatory patients, yeah. The standard is sitting them at the end of the X-ray table. Affected arm resting right on the image receptor, the IR, which is on the table. Nice and stable.
But, not everyone can do that easily. If someone's non-ambulatory, can't move well.
Then the radiographer really has to adapt. You might need cushions, different angles, maybe angle the tube instead of moving the patient quite as much. The goal is comfort as much as possible without sacrificing the image quality. It's a balancing act.
Got it. Then there are the rules about markers and protection. ID markers crucial.
Absolutely. Physical markers, right or left side, placed clearly on the IR before the shot, but not covering the important anatomy. And the sources really stress this point for digital X-ray. You cannot just add the L or R later using software annotation. No way. That marker has to be physically there during the exposure. It's the proof you imaged the correct side in the first place. Adding it later, that negates the whole point.
Makes sense. And radiation safety.
Two key things beyond shielding. First, collimation. Tighten that X-ray beam right down to just the area you need. Second, use the optimal technique, the right KVP and MA settings.
And shielding, of course, even for a hand X-ray.
Absolutely. Gonad shielding is mandatory. Lead apron or shield over the pelvis protects against internal scatter radiation.
Okay. And finally, communication. Explaining the position, maybe demonstrating it.
Breathing instructions usually aren't needed for arms and hands, but the patient must hold still. Even tiny movements can blur the image.
And then you have to repeat the exposure, which is more radiation dose.
Exactly. So getting it right the first time is key.
All right, foundation laid. Now, anatomy. You can't position accurately if you don't know exactly where you're aiming the central ray, the CR.
It's all about the landmarks and the joint names. You need that specific language.
Like if we're talking about the joint between the middle bone and the tip bone of your pointer finger.
You wouldn't just say finger joint. That's the DIP joint of the second digit. Distal interphalangeal joint. Precision matters.
And for a standard PA view of the third finger, the middle finger, where does the CR go?
Specifically, it needs to enter the third PIP joint, proximal interphalangeal. Hitting that joint space dead on is what makes it look open on the X-ray, so you're not seeing the bone ends overlapping.
Okay, moving down to the wrist. Those carpal bones are a jumble. Where's a common problem spot?
Well, the lunate is key. It's that moon-shaped one in the first row of carpals, sitting right between the scaphoid on the thumb side and the truncatrum on the pinky side. Knowing their relationship is vital for understanding wrist injuries.
And the scaphoid itself, probably the most famous carpal bone because it breaks so often. Who's its partner?
That would be the trapezium. It's crucial because it connects to the thumb's metacarpal. When we do an AP view of the thumb, the evaluation criteria specifically say you must see the trapezium clearly.
Does see that whole joint. And quickly, up the arm, the bone on the thumb side of the forearm.
That's the radius, always lateral.
And where the radius meets the upper arm bone, the humerus. What's that part of the humerus called?
The specific spot that articulates with the head of the radius is the capitulum. Remembering the capitulum is really important when we get to the elbow views later, especially the tricky trauma ones.
Okay, anatomy check complete. Let's start climbing that scale of precision. Digits first. Seems simple, but even here, rotation is the enemy. Right. So, for the standard PA projection of digits 2 through 5, index to pinky, position seems easy. Fingers flat, palm down on the IR, spread them slightly. CR perpendicular, aimed at the PIP joint. But how do you know if it's good?
The evaluation tells the story. You need open joint spaces, obviously. But the key check for rotation is looking at the sides of the finger bones, the phalanges. You should see equal concavity on both sides, and the soft tissue shadow should look symmetrical.
Oh, so if one side looks flatter or the soft tissue looks bunched up?
Then the finger was rolled. Even a tiny bit of roll can hide a fracture line, especially on the side that was closer to the IR. And of course, you need the whole finger tipped to the base of the metacarpal.
Okay, PA is about flatness. What about the lateral digits? This gets interesting.
It does, because the positioning actually changes depending on which finger you're imaging. For the index and middle fingers?
The second and third digits?
Yeah. You put their lateral side down on the IR, so the thumb side is down. That's a mediolateral projection.
But for the ring and pinky fingers? Fourth and fifth?
You flip it. You put their medial side down, the pinky side. That's a lateromedial projection.
Why the switch?
It's really just about making it easier and more stable for the patient to hold that specific finger truly sideways, while the other fingers are curled into a fist out of the way. The CR still goes perpendicular to the PIP joint.
And the check for a good lateral.
The fingernail should look like a perfect line seen in profile. You also look for that nice concave curve on the palm side surface of the phalanges, and again, open joint spaces.
Got it. And the third view for digits? The oblique.
The PA oblique digits. Yeah. This is where you need that precise 45-degree rotation, often done by resting the palm side of the finger on a 45-degree foam wedge. Keep the finger you're imaging separated from the others. CR to the PIP joint.
How do you confirm it's really 45 degrees just by looking at the image?
You look at the shaft of the phalanges again. The side that was lifted up by the wedge should show more concavity, more curve. The side that stayed closer to the IR will look straighter. That specific angle helps separate overlapping parts of the bone, giving a clearer view of the cortex.
Okay, that covers digits 2 to 5. The thumb is a whole different beast, isn't it? Because of how it moves.
Completely different. For the AP thumb, you need what's called extreme medial rotation. You basically have to twist the patient's whole hand and arm inwards until the back of the thumb is flat on the IR.
That sounds awkward.
It can be. You often need to tape the other fingers back to keep them out of the way. Center on the MCP joint, the knuckle.
Hand evaluation. Still need the whole thumb tipped down to?
Down to the trapezium. Seeing that carpal bone connection is non-negotiable. And a key sign of a true AP is seeing a little bit of the palm's soft tissue shadow overlapping the middle part of the thumb's metacarpal. If you don't see that, or if the trapezium looks fuzzy or overlapped, it wasn't a true AP. Interesting detail in the sources. A PA view of the thumb actually makes it look bigger, magnified, compared to the AP.
Yeah, because the thumb is further from the IR in the PA position, so the AP is generally preferred to minimize that magnification distortion.
Okay. And the other thumb views? Lateral and oblique. Lateral thumb is more straightforward. Palm flat on the IR first, then rotate the thumb until its side is flat on the IR. Mediolateral projection, CR to the MCP joint. And the PA oblique thumb. Easiest one. Palm flat on the IR. Just tilt the hand slightly towards the pinky side. That's ulnar deviation. CR perpendicular to the MCP joint.
Right, let's zoom out to the whole hand. The basic PA hand.
Palm flat on the IR, fingers slightly spread so they don't overlap. Forearm resting comfortably. The key centering point is the third MCP joint, the middle knuckle.
Evaluation, what are we looking for?
Make sure you see everything from the fingertips down to include the very ends of the radius and ulna at the wrist. And crucially, the MCP and IP joints need to look open. If the patient lets their hand arch up, those joints will look closed off. Flat hand is key.
Okay. Then the PA oblique hand. Why do we need this one?
It's great for looking at the metacarpal shafts and bases, especially the fourth and fifth and the joints between them. You rotate the hand outwards, lifting the thumb side, until the knuckles make a 45-degree angle with the IR.
And you can't just let the fingers curl up.
No, that's a common mistake. You need to support the fingers on a wedge or have the patient keep them straight, parallel to the IR.
Why parallel? It stops the finger bones, the phalanges, from looking squished or foreshortened, and it keeps those little IP joint spaces open. So evaluation is, check for the 45-degree rotation and make sure the MCP and IP joints are open. It's the view for things like boxer's fractures.
Gotcha. Now, the lateral hand. The sources mention two main types.
Yeah, both are centered at the second MCP joint, the index finger knuckle. First is the extension position. Fingers 2 through 5 are kept straight and stacked right on top of each other. The thumb is pulled away, abducted at a right angle.
What's that we're good for?
Often used for finding foreign bodies like a piece of glass or metal, or just getting a general overview in trauma evaluation. Phalanges and metacarpals should be perfectly superimposed, and really important, the distal ends of the radius and ulna must also be perfectly superimposed.
So if the forearm bones aren't stacked, you know the whole arm was rotated.
Exactly. Invalidates the lateral position of the hand. The second type is the fan lateral.
Sounds descriptive. It is. You fan the fingers out, separating them so you can see each phalanx individually. Great for looking at tiny chip fractures or swelling around a single finger joint.
But the rest of the hand still needs to be lateral.
Yes. The key is that while the phalanges are fanned, the metacarpals must remain perfectly superimposed. That confirms the palm itself is truly lateral.
Okay, hand covered. Now for the wrist, that complex junction.
8 little carpal bones, plus the radius and ulna. Yeah, complex is right. The standard PA wrist view, you actually ask the patient to slightly curl their fingers.
Why flex the fingers?
It brings the wrist itself closer to the IR, reduces that object-to-image distance, or OID, sharper image. CR goes perpendicular right into the mid-carpal area. We're looking for no rotation, clean view of the carpals, distal radius ulna, and an open space between the radius and ulna.
Then the lateral wrist. How do we position for that?
Arm rests on its pinky side edge so the medial surface is down, later a medial projection. And the absolute golden rule here is getting the radial and ulnar styloids perfectly superimposed.
Those bony points on either side of the wrist.
Yep. They need to be stacked right on top of each other, and the line through them should be perpendicular to the IR. CR is perpendicular to the wrist joint itself. If those styloids aren't superimposed, you've got rotation, and the carpal alignment is all messed up.
Makes sense. Then the PA oblique wrist. Another 45-degree view.
Yes, 45 degrees, usually using a wedge for support. CR perpendicular to the mid-carpal area again, but this view is highly specific in what it's trying to show.
Which bones benefit from this 45-degree angle?
It's designed to separate the trapezium and the distal half of the scaphoid from their neighbors. The evaluation criteria demand that you see the joint spaces between the trapezium and trapezoid, and between the scaphoid and trapezium, clearly open.
Okay, now for the scaphoid itself. That fracture hotspot, how do we isolate it?
The primary view is the PA rejection and ulnar deviation. You keep the forearm still, but turn the hand outwards towards the pinky side as far as it will comfortably go.
Extreme ulnar deviation.
Exactly. CR is perpendicular, aimed right at the scaphoid, which is in that little anatomical snuff box depression.
How do you know if you got enough deviation?
You look at the angle formed between the long axis of the ulna and the long axis of the fifth metacarpal. Maximum deviation opens up that angle, and more importantly, it pulls the scaphoid slightly away from the other carpals, elongating it and opening up its waist, where most fractures occur.
But what if that's still not enough, or the patient can't deviate that far?
Then we use geometry. The PA axial scaphoid view, also known as the Stetcher method. This involves angling.
Angling the tube or the IR?
Either works. You can lift the finger end of the IR up on a 20-degree sponge, keeping the tube perpendicular to the table. Or you keep the IR flat and angle the X-ray tube 20 degrees towards the patient's elbow.
Same effect, different method.
Exactly. It changes the projection angle through the scaphoid to elongate it, simulating the effect of ulnar deviation. CR still enters at the scaphoid.
Okay, that's clever. And there's one more specialized wrist view, right? A carpal tunnel one?
Yes, the tangential carpal tunnel view, or the Gainer-Hart method. This is a challenge. It's for looking directly down the tunnel formed by the carpal bones.
How do you even position for that?
The patient has to hyperextend their wrist, basically bending it backwards as far as possible, trying to get the long axis of the hand almost vertical. Often they need to grab their fingers with the other hand and pull back gently.
Okay, hand vertical. Where does the beam go? It seems tricky.
It is. The CR isn't perpendicular. It's angled 25 to 30 degrees towards the palm, meaning angled towards the elbow. It enters about an inch below the base of the third metacarpal.
Why that angle?
Because the carpal tunnel isn't straight, it's an arch. That specific angle projects the bones forming the floor and roof of the tunnel tangentially, so you see the space clearly without the bones overlapping each other.
And the evaluation. What absolutely has to be visible? You need to see that characteristic arch shape of the carpals. Two specific bones are critical. The pisiform must be seen in profile, perfectly round, and free of overlap. And crucially, you must visualize the hamulus, the little hook of the hemibone. Why is the hamulus so important?
It's a common site for subtle fractures, especially in sports involving gripping, like golf or tennis. If you miss seeing the hamulus clearly, you could miss that fracture. It's a tiny target that demands absolute precision.
Wow. Okay, the wrist is definitely high on the precision scale. Let's move up the arm to the forearm and elbow. Here, the challenge shifts a bit, right? More about rotation of long bone.
Exactly. Less about tiny corpals, more about making sure the radius and ulna are shown in their true relationship. For the basic AP forearm, it's about getting everything parallel. Elbow straight, hand palm up, fully supinated.
And the key check for rotation at the elbow.
The humeral epicondyles, those bony knobs on either side of the distal humerus, they must be equidistant from the IR, perfectly parallel to it. CRs perpendicular to the midpoint of the forearm.
Evaluation requires seeing the whole forearm, including the wrist and the distal humerus. What happens if the hand isn't fully supinated?
The radius and ulna will cross over each other, especially near the elbow. It can look like an abnormality when it's just poor positioning. In a good AP, you'll see just a slight overlap of the radial head and neck over the proximal ulna, and the space between the radius and ulna should be open distally. And check those epicondyles on the image. They shouldn't look stretched out or squashed.
Okay, now for the lateral forearm. This requires a perfect 90-degree bend at the elbow. Arm rests on its side, thumb pointing up. That's a lateromedial projection. And just like the lateral wrist, the key is superimposition at the distal end. The radial and ulnar styloids must be perfectly stacked, CR to the midpoint again. And this is the real test of a true lateral position for the forearm.
Absolutely. You confirm it by seeing those superimposed styloids, seeing the elbow joint clearly, and critically, seeing the humeral epicondyle superimposed as well. The head of the radius should also sit right over the coronoid process of the ulna. Any separation means rotation.
All right, on to the elbow itself. Lots of moving parts here. It's where the humerus, radius, and ulna all come together. Very complex joint. The standard AP elbow is similar to the AP forearm setup. Elbow fully extended, hand supinated, and those humeral epicondyles must be parallel to the IR. CR, perpendicular to the joint. Evaluation. We want an open elbow joint space. How do we check rotation internally?
You look at the fossa on the humerus, the depressions. The coronoid fossa and the olecranon fossa should look symmetrical relative to the epicondyles. That confirms no rotation. And again, you expect that slight overlap of the radial head neck on the proximal ulna.
Okay, now the crucial shift for the lateral elbow.
Game changer. Elbow flexed 90 degrees. But now the humeral epicondyles must be positioned perpendicular to the IR, stacked one above the other, CR perpendicular to the joint.
So AP is parallel epicondyles, lateral is perpendicular epicondyles.
That's the fundamental rule. For a true lateral elbow evaluation, you check for the 90-degree flexion open joint, and you also look really carefully at the soft tissues around the joint for elevated fat pads.
Ah, the fat pads. Tell me more about those.
There are fat pads nestled within the elbow joint capsule. If there's swelling or bleeding inside the joint, often from a fracture you can't even see yet, that fluid pushes the fat pads out of their normal position, making them visible on the X-ray. It's often the first and sometimes only sign of an occult injury.
Incredibly important sign, that. Okay, what about the oblique elbow views?
Both are 45-degree rotations designed to profile specific bony landmarks. For the AP oblique with medial rotation, that's internal rotation, you pronate the hand, palm down, and rotate the whole elbow inwards, 45 degrees.
What structure are we targeting with medial rotation?
The coronoid process of the ulna. This view should show that beak-like process completely in profile, sticking out anteriorly, free from the radial head. You'll also see the medial epicondyle looks elongated and the olecranon process sits nicely in its fossa.
And the opposite rotation, lateral oblique.
AP oblique with lateral rotation, external rotation. Here, you supinate the hand, palm up, and rotate the elbow outwards 45 degrees. The patient's thumb and index finger will likely touch the table.
And this view isolates.
The radial head, neck, and tuberosity. They should be projected completely free of the ulna, no overlap. This is often the money shot for subtle radial head fractures. The lateral epicondyle will look elongated, and you get a good view of the capitulum.
Okay, those are standard. But trauma happens. What if the patient can't fully extend or flex their elbow?
Yeah, common problem. We have adapted views. If
Yeah.
they can only partially flex, and you really need to see the distal humerus well,
Maybe looking for a fracture just above the elbow.
right, a supracondylar fracture.
Yeah.
You position the humerus itself flat on the IR. The CR goes perpendicular to the humerus through the joint. You might need to angle the tube a bit distally to keep it perpendicular to the bone, not the forearm.
What's the downside?
You get a great view of the distal humerus without rotation, but the forearm bones will look very short, foreshortened, and the elbow joint itself will look closed. You sacrifice the forearm view to get the humerus clear.
And the opposite scenario, focusing on the proximal forearm when the patient can't extend fully.
You rest the back, the dorsal surface of the forearm on the IR. Now the CR needs to be perpendicular to the elbow joint and perpendicular to the long axis of the forearm.
So here, the forearm bones look good.
Yes, the proximal radius and ulna, especially the radial head and neck, are seen without rotation. But now the distal humerus looks foreshortened. The elbow joint might be partially open, giving some info. It's always a trade-off in trauma.
Which leads us to the really specialized trauma views, right? The coil method.
Exactly. The axiolateral projection, or coil method. This uses significant tube angles to project specific parts free from overlap when the patient absolutely cannot move into standard positions.
Okay, walk me through this. For the radial head using coils, elbow has to be flexed 90 degrees. Hand pronated, palm down. Then here's the key. You angle the CR 45 degrees towards the shoulder. 45 degrees towards the shoulder. That seems counterintuitive.
It does, but that specific angle projects the beam right through the joint space between the radial head and the capitulum, opening it up beautifully. The radial head and neck pop out in profile. The little radial tuberosity should be pointing backwards.
Amazing. Now, how subtle is the change to see the coronoid process with coils?
Incredibly subtle positioning change, massive angle change. First, the elbow flexion changes just slightly to 80 degrees instead of 90. Hand stays pronated, but the tube angle completely flips. Now you angle the CR 45 degrees away from the shoulder towards the hand.
Wow, just 10 degrees difference in flexion and flip the angle 90 degrees total.
And that projects the coronoid process out, clear of the humerus. You'll see the joint space between the coronoid and the trochlea open up. The coronoid itself looks elongated, in profile, and in this view you expect the radial head to be mostly hidden, superimposed by the ulna. You sacrifice one to see the other. It's the epitome of targeted imaging. Really shows the precision needed.
Okay, last bone, the humerus itself. Upper arm bone. For the AP humerus, you want the top edge of the IR about 1.5 inches above the shoulder joint, the humeral head. Arms slightly abducted, away from the body, hands supinated. And again, the key is getting the epicondyles parallel to the IR, CR perpendicular to the middle of the humerus.
How do we evaluate the rotation on an AP humerus?
You look at the tubercles at the top. The greater tubercle should be seen in profile sticking out on the lateral side. The lesser tubercle should be visible more anteriorly, just outlined between the head and the greater tubercle. If the epicondyles aren't parallel, these landmarks get distorted.
And for the lateral humerus? You typically have the patient internally rotate the arm, maybe flex the elbow 90 degrees, and rest the back of their hand on their hip. Now, the epicondyles need to be perpendicular to the IR, CR perpendicular to the mid-humerus.
Evaluation check. Epicondyles should look superimposed. And now the tubercle view flips. The lesser tubercle should be seen in profile on the medial side of the humerus. The greater tubercle gets superimposed over the humeral head itself. Getting these profiles right is crucial for assessing shoulder issues, too.
Okay, we've covered a huge amount of positioning detail. Let's try to synthesize this. What makes an image truly diagnostic, beyond just getting the patient in roughly the right spot?
Well, all that positioning effort is wasted if the basics aren't right. Collimation and technical factors. Every single view needs clear evidence of tight collimation, those visible beam edges. The exposure needs to be right to see not just the bone outlines, but the fine bony trabecular detail inside and the surrounding soft tissues.
Then the collimation isn't just random, right? There are specific rules mentioned. Yeah, absolutely. Like for the AP thumb, you need to include bone at least 1 inch proximal to the CMC joint, that thumb wrist articulation, because problems often happen there.
And the PA hand.
Needs to include 1 inch of the discal radius and ulna. You need that context of the wrist joint for assessing hand injuries properly.
And the PA wrist itself.
Requires a pretty generous field, about 2.5 inches proximal and discal to the joint itself. You can't cut off the ends of the forearm or the start of the metacarpals.
Okay, so collimation is key. Let's quickly recap those crucial rotational checks, the common pitfalls. The big one is the elbow and forearm. Humeral epicondyles parallel to the IR for AP views, AP forearm, AP elbow, that prevents crossover, and epicondyles perpendicular to the IR for lateral views, lateral forearm, lateral elbow, lateral humerus.
Get those two straight parallel for AP, perpendicular for lateral, and you've mastered a huge part of upper extremity rotation.
For the wrist, the absolute check for a true lateral view.
Superimpose distal radius and ulna, no daylight between them. If they're separated, it's rotated, period.
And back to the elbow one last time. Which view best shows the olecranon process, the pointy part of the elbow?
The true lateral projection of the elbow is the only one that shows the olecranon clearly in profile. If that curve isn't sharp and clear, you've likely got rotation, which might also hide those important fat pad signs.
Okay. So we started talking about the scale of precision, and what we've really detailed is this incredibly complex, almost choreographed set of procedures.
Yeah, it's not just pointing and shooting. Every view, from a simple finger PA to that complex coil method for the elbow, hinges on mastering these tiny adjustments. 45 degrees here, 20 degrees there, making sure things are perfectly parallel or perfectly perpendicular.
It's fascinating how you have to mentally visualize this 3D anatomy and figure out how to position it and angle the beam just right to flatten it onto a 2D image effectively.
And knowing exactly where to aim that central ray PIP joint, MCP joint, midcarpal area, that's what opens up the joint spaces, separates the bones, and lets you see tiny things like the hamulus hook or a hairline radial head fracture.
The level of underlying knowledge required is just immense. You have to know the anatomy inside out and predict exactly how even a few degrees of rotation will change the entire picture.
Mm-hmm. That difference between a true lateral and an oblique, or between the coil radial head view and the coil coronoid view, it's walking a tightrope. But getting it right can literally change the course of treatment for a patient by finding or ruling out a serious injury. So we've seen how critical this precision is for specific injuries. Here's a final thought to leave you with. If just a tiny deviation, maybe less than 5 degrees off that required 45-degree oblique, could potentially hide a fracture and lead to a misdiagnosis. What does that really tell us about the level of specialized skill and intense training needed for all kinds of diagnostic imaging where the stakes are this high? And maybe consider this too. How does that radiographer's ability to achieve this physical perfection day in and day out act as a fundamental protection for the patient, potentially saving them from months or years of pain and complications that a misdiagnosis could easily cause?